Hello, and thank you to the organisers, first of all, for inviting us to talk with you today. Um, Firstly, to introduce ourselves, my name is Jo Lowndes, and I'm a genetic counsellor, and I work in the mitochondrial disorders service in Oxford. And joining me today is my colleague Sian Jenkins, who is a genetic counsellor who works at the Oxford Eye Hospital. Um, we should first of all say that we've been asked to talk about genetic testing and your family today, but we apologise that the nature of this topic is really only likely to be relevant to a proportion of the membership, i.e. those with inherited retinal dystrophies and the working age members. So for our agenda today, I'm going to start the presentation talking a little bit about what the role of a genetic counsellor is, so what it is Sian and I do. You may never have come across a genetic counsellor before. And I want to illustrate the work that we do and the way that we support our patients and families with a couple of case illustrations from my clinic. Sian will then take over and she's going to talk about what you can expect from your genetic eye clinic appointment. And she'll talk about genetic testing for inherited eye disease specifically in more detail. And we hope to leave a little bit of time at the end for your questions and any conversation. So what is genetic counselling? Well, I think genetic counsellors, we aim to help our patients in several ways. First of all, we're trained to interpret family and medical history information to assess the chance of a genetic condition occurring or reoccurring in a family or in another family member. We also provide information. We educate our patients, families, other healthcare professionals about inheritance, about genetic testing, the management of specific genetic conditions, their prevention in some cases, and the research in the field. But many of us are trained with counselling training and have counselling skills, and we use these also to promote both decision making for our patients and their families. So maybe there are decisions that people are finding not easy to make around whether to have genetic testing or not. And we're also there to support and counsel our patients and families in their journey adapting to their genetic condition or the risk of their genetic condition. When I think about the impact of a genetic diagnosis on a patient, the first image that often springs to my mind is that one of ripples on a pond. When you throw a stone into still water, you get ripples. And I think a genetic diagnosis for a patient is not only obviously important to that individual, but it can also be very relevant to members of that person's family. So maybe their sisters, children, brothers, aunts, uncles, parents, lots of people in the family potentially. And as genetic counsellors, this is something that we're very aware of, and we will often see multiple family members from one family in our clinics. And if you ask most genetic counsellors, I think they would say that whilst they also, they have a professional duty to the patient in front of them, we also have an obligation to care for and think about the wider family, maybe the people that aren't in the clinic room with us in that moment. And we have a responsibility to try and ensure that the genetic information for one person is disseminated through the family where it's needed. I think the relevance of the family and the questions around family are also important to patients as well. When a patient is first diagnosed with a genetic eye condition, quite understandably, the first question can often be, will my vision get worse, or is there a treatment or cure? But very often, the next question is, what are the chances my children might get this, or somebody else, another relative in my family? And the answers to this question will often depend on the gene involved, the inheritance pattern, and the genetic relationship between the patient and their relative. Sometimes we can be reassuring about the chance of a condition in another person in the family, but sometimes the chance is much more significant. Patients will also ask, can my family have genetic testing? And generally speaking, to be able to offer a genetic test to a family member at risk, maybe somebody who hasn't yet developed any symptoms, we'll first need to identify in the affected person the alteration in the gene that we think is causing that person's condition. Genetic testing isn't always appropriate, and it's going to depend on the pattern involved and the level of risk. We don't. We also have to consider the age or stage of that family member. So, for example, we generally don't consider genetic testing in very young people for carrier status. Being a carrier doesn't generally affect your own health, but it can have implications when somebody is having children. So in that case, it may be more appropriate to wait until the child is a young adult or of an age where they're maybe thinking of having their own children, and they can make their own decision around genetic testing at that point. The question about what are my options in pregnancy is probably not a question that we get asked very often in the eye clinic. But some patients do wish to discuss their options for having a family and avoiding passing the genetic condition to the next generation. And these sorts of choices are very much individual to every couple. And I think all of these questions that patients come with to clinic can often be overlaid with feelings that get raised, maybe difficult feelings, as a consequence of having a genetic condition in the family. And patients have very real concerns, for example, about how they're going to tell their relatives or inform their family members about their genetic condition. And it's our role as genetic counsellors to really help address these difficult feelings and concerns that patients have. So I'd now like to illustrate this by using a couple of anonymised patient examples from my own clinic. And I apologise, these examples are from my work in the mitochondrial clinic. So these patients don't have macular disease, but I think that the messages that are raised and illustrated are really universal and common to all patients that we see. So with the first example, I met with a 55-year-old lady who had a family history of a condition known as Leber's hereditary optic neuropathy, or LON for short. And that's not to be confused with the retinal condition Leber's congenital amaurosis. They're two different conditions. But LON is a condition that can affect both males and females. It generally speaking can come on at any age, but is maybe more common in the younger age, sort of teenage or young adults. And people with LON, if they develop the condition, can have a visual impairment that means that they are either registered as sight impaired or even severely sight impaired. My lady came to clinic. She herself had no eye problems at all. She was bitten well and her vision was good. But she had various family members, so two brothers and a sister, and a maternal uncle and other family members who had all developed visual problems due to LON. And she came to clinic asking the questions, what's my risk of developing this condition? And she wanted to understand what it could mean also for her children and her grandchildren. So we talked about her risk and the risks for others in the family. We discussed how this condition is a maternally inherited condition. And whilst the genetics of it are complex, what we do know is that your chance of developing the condition will depend on your age, but also your agenda. So, for example, we know that males have a greater chance of developing LON compared to females in a family. And whilst her risk was low for herself, we also talked about how she could manage her risk. So factors such as alcohol and smoking, which are additional factors that can increase somebody's chance for developing LON. We talked about how screening through seeing an eye doctor on a regular basis wasn't necessary, but that she ought to have a low threshold for reporting any concerns with her vision at any point with her optician or her GP. And this was particularly important because there is a treatment that is helpful to some patients with LON if it's administered early enough in the disease course. We talked about genetic testing, the genetic testing that we could offer her. Um, to do a test for this lady, I had to ask her to seek permission from her brother to be able to access his genetic test report so that we could make sure that we were doing the right test for my lady. And we talked about the genetic testing that was possible for her children as well. Now, in terms of the psychological and emotional impact of the condition within this family, I think they were a well-informed family. My patient knew a lot about Lon before she came to clinic, and she also described how her relatives, particularly her brothers who had lived with their visual impairment for many years since their teens, were positive role models for people living with a visual impairment. She was reassured and relieved at now being more informed at following a consultation, and she felt comforted by the potential of a treatment in the future. And she reflected that with support, that perhaps she would be able to manage if she did develop a visual impairment due to LOM. And I think that's really because of the positive role models that she had already within her family. I'd describe the communication style of this family as an open communication style, and my lady very much took it upon herself to have the responsibility for passing on the detailed information that we discussed in clinic to her children, her grandchildren, and other people in the family. In the second example, this time in clinic, I saw a 41-year-old lady. She also had a family history of LON. Her brother had been diagnosed with the condition at the age of 34 and relatively recently, but there was no other family history of the condition. Her questions were very similar to those of the my first case. She asked, "What are the risks for my children, and can we all have genetic testing for this?" And whilst much of the discussion around the risk assessment, how to manage the risk within the family, and genetic testing was very similar to the first case that I described, I think in contrast to the case one, the psychological aspects of this consultation were very different, and the lady required much more support. The knowledge of her brother's diagnosis had been very recent, and it had come out of the blue for her and her family. And in fact, it was her parents that had told her about her brother's diagnosis. And they'd actually taken almost up to a year to find a way of having that conversation with her. She was very shocked and distressed at her first appointment in clinic. And in particular, I think she was very angry. And she expressed a potential guilt for possibly passing this condition on, particularly to her son, who had a greater chance for developing the visual impairment. And she was worried that he would go blind and that I had caused it, were her words. I think guilt is a very common and perhaps universal feeling for parents in the context of a genetic diagnosis in a family. In clinic, we use our counselling skills to help normalise and reframe that kind of parental guilt. And I think that can be very helpful to families. After all, none of us are genetically perfect, and it takes more than to be a parent than the genes that we pass on. I think for this lady, overall though, her most challenging aspect of the consultation and the information that we discussed, well, for her, her concern was how she was going to tell her children, how she was going to pass on that information. And in my experience, that's true for many of our patients and our families with living with genetic disease. And while she recognized the importance of passing the information on, she naturally wanted to protect her children. They were approaching their teens, and she feared their reaction. What if they're angry with me? What if they shut the door in my face? And I think it highlights that being a messenger of that news can be a burden as well as a responsibility that some people feel that they need to do. So I supported this lady. We talked about the words that she might use. We rehearsed the conversation that she might have with her children. I encouraged her to make the topic something that was not taboo, something that was okay to talk about, and it was okay for her children to ask her questions around. For many families, Sean and I will provide to whom it may concern letters, and these are ways of passing on that information or starting that conversation within the family, and give the family members an idea of where they can go for further information and advice. So I hope these cases have given you a clearer idea about genetic counsellors and how we help our patients and families. And now I want to hand over to Sian, who's going to tell you a bit more about what happens in the genetic eye clinic in Oxford, and talk to you a bit more about genetic testing for inherited eye diseases.
Thanks, Joe. As you can tell from all that information is quite complicated, some of the stuff that we go through in the genetics clinic within the um, eye hospital. So what I'm going to do now is cover a bit more of the practical side of how the genetics clinic works within an ophthalmology department in an NHS hospital. I'll base this on what we do in the Oxford Eye Hospital, but different regional centres might do things slightly differently. Um, the ophthalmologist that you see on a regular basis or your GP would be the best person to go to for advice about how the service works in your local area. So here at the Oxford Eye Hospital, we receive referrals from GPs, local hospital ophthalmologists, opticians, and regional genetic services. Um, People are usually referred to us as they are suspected of having an inherited eye condition, and this will often be because of the way the eye looks or behaves. This could be something as basic as the age in which your macula has started to deteriorate is a particularly young age. It might be because the deterioration is equal in both eyes, which is common in genetic conditions. Or in other cases, it could be that the particular pattern of the deterioration at the back of the eye in the macula um, is significant and kind of pinpoints a particular inherited condition. Sometimes a person is referred to us without any symptoms because they already have a family history of a known genetic eye condition. So, for example, you might know that your mother or your or father have um, macular dystrophy of some kind, and you've been told that there's a chance that you might also inherit that. We would continue to see people who have had a diagnosis of macular dystrophy, um, and this could be on an annual or every 2 or 3 years basis, kind of as an MOT, just to keep on top of how your vision is and other aspects of the way that your eye functions. Um, it's also an opportunity for us to update you on any research or developments in the field, um, and also for you to ask us any questions you might have as time has gone on with the diagnosis. We know that the impact of a genetic diagnosis changes with the different stages of life that we go through. Particularly if you were diagnosed at a young age, you might have questions, for example, when you start being able to learn to drive, if you're thinking about having your own family. Um, we're there to help you navigate through those life stages. We're really fortunate at the Oxford Eye Hospital to have some world-renowned consultants who have a specialist expertise in ophthalmic genetics. Um, these include Professor Susan Downs, Professor Robert McLaren that you've just heard from, Professor Peter Isser, Professor Dominic Fisher, and Miss Samantha De Silva. We also have the privilege of working with the Oxford Eye Research Group, who keep us up to date with all the developing research. As Joe mentioned at the beginning of the presentation, only a small proportion of individuals who have problems with their macula are down to an inherited genetic cause. We know that most disorders that affect the macula are related to age and that we develop them as we get older. Although age-related macular degeneration, or AMD, as you will probably refer to it, can have some genetic factors that influence the chance of us going on to develop it. We can't pinpoint it to one single gene where there's been one alteration which stops the gene from working. And that's the case in an inherited macular dystrophy. So here I just list some examples of macular dystrophies, and these include Stargardt macular dystrophy, Best disease, pattern dystrophy, bullseye maculopathy, Doyne's honeycomb dystrophy, Zorby's fundus dystrophy, North Carolina macular dystrophy, and pseudoxanthum elasticum, also referred to as PXE. These generally affect people at a younger age, sometimes from childhood, although some of the symptoms can be quite mild, so sometimes aren't diagnosed until later in life. Like we mentioned earlier, there are some signs and symptoms that would suggest that your macular condition is genetic. And these would be obvious to your ophthalmologist or optician. And if that was the case, then they are likely to have already discussed this with you and suggested a referral to a specialist centre. It might be that you have got a family history of somebody who has the same type of eye condition, so it might be seem a bit more obvious to you that this could be down to something genetic. If you're not sure at the moment and you feel you would benefit from discussing whether there's a genetic factor to your macular condition, please do ask your regular ophthalmologist or optician whether a referral would be beneficial to you. Once you've been referred to the genetic clinic within the eye hospital, you might be contacted by a member of our team to find out a bit more about your eye history, other medical history, and your family history. And we're very aware that being asked this information, particularly about family history, can be quite overwhelming. It's not something to worry about. It's just something that will help us get a clearer picture of what's going on for you in the hope to be able to provide you with as much information as possible when you come to see us. Sometimes more testing is needed before you come to your appointment, and this could include looking at your visual fields or having electrodiagnostic testing where we look at the function of the eye. This is also a good time for you to have a think about any questions you might have for us. It's a good time to have a conversation with your family and your loved ones about the possibility of a genetic diagnosis. And it might be sensible just to write down some of those questions for when you come to see us, because it can be quite an overwhelming appointment. When you do come to see us in the Oxford Eye Hospital, you will see a number of health professionals, and there'll be a number of tests that you will have on the day. These include things like checking your visual acuity, so that's when you look at the letters on the board, and you'll have lots of different photographs taken of the back of your eye, which will look for signs and symptoms that this could be genetic. You might have some of those tests that I mentioned earlier, visual fields and electrodiagnostic, on the day if you hadn't had them before you came. So it can turn out to be quite a long day, and you can be expected to be in the department for several hours. We appreciate that that's really difficult and a long time to be in one place, but so that we can provide you with a really thorough look at what's going on with your eyes and provide you with the best information that we can on the day. You'll be seen by one of the doctors who work within the genetics team, and that might or might not be the responsible consultant, but the team work really closely together, and all decisions will be made in discussion with everyone throughout the team. They will discuss the results of all those testing that you've gone through throughout the day or previous appointments, and might be able to, at the appointment, give you a bit of an idea of what the diagnosis might be. If they decide that your eye condition could be caused by something genetic, then you will likely go on to see a genetic counsellor like myself during your appointment. So genetic testing may be considered to try and confirm the specific cause of your eye condition. So a genetic counsellor would sit down with you and discuss the process and the implications of genetic testing, not only for you, but for your wider family. And you would be able to decide at this point whether this is something that you would consider going ahead with. There's no requirement at this stage to proceed with genetic testing. You might opt to take some time to go home and discuss that with your family, or you may feel ready and informed enough to go ahead with that test there and then. Genetic testing requires a blood test, and we then send that sample to our laboratory to look at your DNA code to see if we can find any specific alterations which would explain why you've developed this eye condition. So genetic testing technology has obviously developed over the last few years. If you've had genetic testing before, it's likely that you provided a blood sample for a single gene test, looking at one specific gene, or even more recently, you might have had what we refer to as panel testing, looking at a number of genes that we know are associated with eye conditions. We are now able to look at the entire DNA code, so something that we refer to as whole genome testing. And although this will initially focus on genes that we know are associated with inherited eye conditions, we can also look at the rest of the DNA code to see if we can identify new causes or rare causes for macular dystrophies. Over the last few years, NHS England have been working to improve and integrate genomics into every aspect of NHS healthcare. And one aspect of this is the new NHS National Genomic Test Directory. And this outlines the full range of tests that are funded by the NHS in England and sets out which tests are available and the patients who are eligible to access those tests. So that means no matter where in England that you go, you should be accessing the exact same test as somebody who, for example, came to the Oxford Eye Hospital. Once a result is available, we would sit down with you and discuss that result and its implications not only for you, but for the rest of the family. If we're not able to find an underlying cause for your eye condition through the testing that we've done at this time, it doesn't mean that your eye condition is no longer thought to be genetic. It means that we've just not been able to pinpoint the specific cause, and that is something that can happen on a regular basis in this kind of testing. Further testing is sometimes available through one of our research projects, and if that's the case, we would refer you to our research team who will be able to talk you through the next 3 steps with that. Unlike other tests that you would usually have during a hospital visit, genetic tests don't just produce a result for you, but as we've already discussed in this presentation, it's a result that might have implications for other members of your family. It's something you will consider and discuss in depth before you go ahead with the genetic test. And as Joe has discussed earlier, the impact for your family will really depend on the specific inheritance pattern associated with what we found in your genetic test. So again, your genetic counsellor would explain that in depth, what the risks were for other family members, and how they can go about using that information for their own health. We understand that this is a huge area of concern for a lot of people when they go through genetic testing. And so that's something that we would be available to support you through, as Joe mentioned, sharing that information to the relevant people in your family. Once a genetic cause has been confirmed, your family members might go on to decide to do their own genetic testing. And that is usually done through their local clinical genetics service. And this is something that is called predictive genetic testing. This is routinely people who don't have any symptoms of this genetic condition, and they're looking to see whether or not they've inherited that specific gene alteration which causes the condition, and therefore it's predicting whether or not they will go on to develop that condition when they are older. This test is only possible if we've identified the cause of the genetic eye condition in the affected family member, so in you. So it's really important that we get to the bottom of that first before we think about testing in anyone else in the family. So as you can tell, the information surrounding genetics is really quite complex, and that's what we're here to do, is try and support you and your family to understand how this can impact you and your family. Um, Hopefully kind of this whistle stop tour that we've just gone through has highlighted some of the practical and the emotional aspects of going through genetic testing. Um, However, it would be really important for you to sit down um, with somebody who can go through your specific um, circumstances. So if this is something that you think is relevant to you and you've not had the opportunity to speak to um, a specialist centre or genetic counsellor in the past, then please do ask if you can be referred, and probably the best point of contact for that would be your GP. So thank you very much for listening to Joe and I today, and we are available if you have any questions or anything that you would like to discuss. Thank you very much.